Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Ashinsky of RWJBarnabas Health Medical Group. Together with Rutgers Cancer Institute, the state's leading cancer program and the only National Cancer Institute designated comprehensive cancer center, RWJBarnabas Health provides patients with the most advanced treatment options, including clinical trials, immunotherapy, precision medicine, complex surgical procedures, and sophisticated radiation therapy techniques. On today's show, we will learn more about certain types of cancer and the innovative treatment options that are available. We are pleased to welcome Dr. Joel Braver, the Medical Director of Radiation Oncology at the Steeplechase Cancer Center at Robert Wood Johnson University Hospital, Somerset. Dr. Braver is affiliated with the Rutgers Cancer Institute. Welcome to the show. Thank you, Dr. Braver, for being here. For the audience, can you tell us a little bit about your background, who you are, where you're from, where you went to school, and how you ended up at the Robert Wood Johnson University Hospital, Somerset, Steeplechase Cancer Center?
Thanks, Doug. My name is Dr. Joel Braver. I'm the Medical Director of Radiation Oncology at the Steeplechase Cancer Center. My background is I grew up in North Jersey and went to University of Pennsylvania as an undergraduate, and then Robert Wood Johnson Medical School here in New Brunswick, New Jersey, followed by a residency in radiation oncology at Montefiore Medical Center. Growing up in New Jersey, I always kind of wanted to come back to my home state, and I was fortunate enough to, coming out of residency, to obtain a position right here in central New Jersey. We used to be in a freestanding center before Robert Wood Johnson Somerset had radiation oncology, but we were able to help design and build the center here at Somerset Medical. What used to be Somerset Medical is now Robert Wood Johnson Medical Somerset Hospital, University Hospital. Basically, I've been on staff at the hospital here for 28 years. It was helped design the radiation oncology department, and have been very fortunate to help see the progress of the radiation oncology department.
First of all, thank you for doing everything that you've been doing for all of these years. Treating cancer is very, very difficult. Radiation oncology, what does that mean, and what should the studio audience know about radiation oncology? So
what the studio audience needs to understand is that cancer is not just one disease. It's thousands of different diseases, and having to do with abnormal cell growth. And cancer can be treated in a variety of ways: surgery, through medications such as chemotherapy, immunotherapy, that's done by medical oncologists, or with radiation treatments, which is what I do. Radiation treatments are given by radiation oncologists. So oftentimes a cancer may be treated with one modality, which would be surgery to reduce the cancer, and that's usually done by a surgical oncologist, or it may be treated with medications and immunotherapy by medical oncologists. But more often than not, it's treated what we call multimodality, all three modalities: surgery, chemotherapy, immunotherapy, and radiation therapy. So the most common cancers we treat are breast cancer and prostate cancer. So for breast cancer, a woman may undergo what's called a lumpectomy or partial mastectomy, where they remove a portion of the breast, or they may undergo a mastectomy, where the entire breast is removed. Often with these surgeries, they will need some sort of adjuvant or what we call additional treatment, such as hormonal therapy, chemotherapy, and or radiation therapy. So the standard of care for younger women with a lumpectomy is to give additional radiation treatments to reduce the odds of it recurring. Even in some patients where a patient may have the entire breast removed, they still may be at high risk for recurrence, and that's where radiation comes in to reduce recurrence and improve survival.
So again, what the people need to understand, cancer basically is an abnormal growth of abnormal cells. And it can occur in multiple places of the body, and the most common ones that you treat are the breast cancer and you said the prostate cancer.
Correct.
And they're treated multidisciplinary. You know, they may be treated initially with things like prostate cancer, may actually be initially just waiting, watching to see if something happened before we did some type of modality. Some of them may be treated with some type of surgical intervention, and prior to the surgical intervention, the oncologist may determine that giving some type of IV medication prior to surgery may be helpful, and then afterwards giving IV medications afterwards, as well as radiation afterwards, to prevent recurrences may be necessary. Are there risks for developing these type of cancers?
Well, there's always risks for different types of cancers, so that a lot of cancers, may be a genetic component, particularly breast cancer. There are certain genetics that we check that may put a patient at a higher risk for breast cancer. There are certain dietary factors that probably link many of the cancers that right now science hasn't quite got up to what is causing them. We think that the processed foods, just like they put you at increased risk for cardiac disease, may also put you at increased risk for cancers. But we haven't proven a substantial link to a lot of dietary things with cancer, though there are certain cancers that are dietarily linked. Genetics for breast and prostate to some degree, but not quite as the same as breast for prostate cancer. Certainly colorectal cancer, there's a very large genetic component to that. The good news is that for colorectal particularly, we have very effective screening methods.
And of course, the problem with many cancers is we don't find them until they're too late because they do not have signs or symptoms of it.
Correct.
The good news is that with the Institute of Mammography, we are definitely catching more breast cancers earlier than we prior had, and therefore it's very important that women starting at age 40 start doing breast cancer screening on themselves. For prostate cancer, that's always been a question. You know, it used to be, we used to always do digital rectal exams. Now, we had found out that we were overdoing it, and so now it's more of the PSA seeing, and if the PSA either goes up more than 1.0 in a year or it goes greater than 4 in a younger man, that it's time to see the urologist, consider an MRI in the prostate, consider a biopsy. But most of the time, there's not many symptoms. Colon cancer, possibly you may see some blood, or you may have some loss in weight or something like that happening. So the problem with a lot of these is there are not many signs or common signs or symptoms are with them.
Correct.
And then the thing we need to do is we need to every year explain to people how important it is to maintain a good, healthy lifestyle in order to hopefully avoid the risks of developing the cancer. So if you're a smoker, give up the cigarettes. If you're overweight, please work on a diet exercise program. Talk to a dietitian, nutritionist, work on some type of a program. If you're eating a lot of processed foods, please try to see if you can change that. Go to more of a good, well-balanced diet and try less processed foods, because we think that may increase the risk of developing a cancer. So someone has a cancer, they see a specialist. Are there different, as we described, there are different treatment options. And the important thing is that you, as part of Robert Wood Johnson University Hospital, also coordinate with the Rutgers Cancer Institute, which is the state's leading cancer program and the only national Cancer Institute designed comprehensive cancer center, which makes it very important. You work in a team approach. You have advanced treatment options, which include clinical trials, immunotherapy, precision medicine, complex surgical procedures, and sophisticated radiation therapy, which is not available at other places. So being in a National Cancer Institute designed comprehensive cancer center means the patients are getting the best possible quality care necessary.
Those are great points, Doug. So I work here at Robert Wood Johnson University Hospital, Somerset, but my employer is actually Rutgers Cancer Institute in New Jersey. And we have multiple centers throughout the state that are affiliated through Rutgers Barnabas Health. And so when you see one of us here at Somerset, you're actually getting a much larger team than you imagine. We have about 25 radiation oncologists who we consult with on almost every single case. We have weekly planning rounds where we discuss all our definitive cases with the entire team. So we get the input not just from the two doctors here at Somerset, but the entire radiation oncology team. It also gives us access to, as you mentioned, very advanced equipment. For instance, in New Brunswick, we have what's called proton radiation therapy. Okay, proton is a means of delivering radiation slightly different than what we do, which is X-ray or photon therapy. Proton therapy has shown some clinical benefits, particularly in pediatric tumors and some other cancers, particularly if their area has previously been irradiated. And very few centers in the country do proton therapy. So we have that. In addition, we're building a new cancer center in New Brunswick, which will have what's called an MRI LINAC. So we'll do real-time imaging via MRI while a cancer is being treated. The idea of radiation is that you're trying to treat the target, which is the cancer, and minimize radiation therapy to the surrounding structures. Well, patients move, organs move within the body, so that what we do is immobilize patients, and we try and target as accurately as possible the structures internally in the body. And we can do that with imaging while the patient is being treated. Typically, we'll do an image, line up to the internal structure in the body, and then treat. The next advance in radiation most likely will be this MRI-guided imaging, which will be real-time MRI as the patient's being treated, as opposed to image and then treat. It'll be imaging during treatment with adjustments being made during the actual delivery of the radiation. That being said, most cancers these days don't require that level of sophistication. But we always want to be as accurate as possible. Recently, we installed a new linear accelerator called the TrueBeam Linear Accelerator. This is a state-of-the-art linear accelerator, which is the workhorse of any radiation oncology department. The advantage of the new linear accelerator is our imaging capabilities on the machine have greatly improved. So we're seeing more accurately what's going on inside the patient by doing a CT scan right before their treatment. We have what's called a 6-degree of freedom couch, so that when we line up with a patient on the table, the patient's lying on a table, we're comparing that to the plan that was generated at the beginning of prior to treatment, what we call a planning session, a CT simulation. The way we line these patients up is we actually have the patient hold nice and still, but we move the table that the patient's on. We can move the table up, down, in, out, left, right. Now we've added pitch and yaw to the table so that we can really line up the patient very, very accurately. Now, this is both externally and internally. By doing a CT on the machine, we can look at the rotations inside and rotate the table to accommodate the shifts that were made compared to the planning session. The other thing this new machine has is what's called surface-guided radiation therapy. This provides sub-millimeter accuracy. And what this is there's a 3D stereotactic cameras throughout the room, and they create a surface map on the patient with thousands of points of light. And we compare this to a surface map that was created during the planning session. And these maps should line up very, very accurately. The machine will actually give you a green light if you're lined up, red light if you're not. And what happens is the surface is being monitored as the patient's being treated. And if that patient moves outside of the parameters that we set, which are millimeters, the machine will actually shut off the beam until the patient is realigned. So it's very, very accurate. And this decreases radiation to the surrounding tissues. So right now we're using it in breast patients. We're using it in patients who are being treated for brain metastases. So the old days, patients would have to have a frame screwed to their head to treat brain metastases. Now we can just do a mask, which is open, not claustrophobic, nothing being screwed to the patient's skull, but rather the mask is affixed to the table. The patient is immobilized. We're looking at the surface imaging. We're also looking internally to make sure that the bony anatomy is lining up. So we're doing both surface and CT imaging to line these up. We're monitoring it throughout the course of treatment to make sure the patient's surface is not moving. The accuracy is tremendous. And now we have some new technology as well called hyperarc therapy. And as I was talking about, patients get what's called brain metastases. These are cancer from other parts of the body that have spread to the brain. For instance, in more advanced breast or prostate or lung cancer, it's not uncommon to see lesions spread to the brain. If there's a single lesion, patients may have that surgically resected. Even with that, we're still going to give some radiation because that's been shown to increase local control. But if patients have multiple lesions, they need radiation. You can't remove multiple lesions in the brain because the brain would end up looking like Swiss cheese. We have this new technology called hyperarc, and this allows us to treat up to 20 lesions in the brain within 20 minutes. Previously, it would take 2 to 3 hours to treat that many lesions, and patients would have to have a frame screwed to their head. So the technology is moving forward very, very rapidly, and it's a wonderful thing to see. And the quality of life for patients is much better than previously. Patients are getting months or years of quality of life that they previously would not have experienced.
So again, the important thing that this all goes back to is the fact that since you are part of Rutgers Cancer Institute, which again is a National Cancer Institute designed comprehensive cancer center. You have a team approach to the patient. The patient has a diagnosis. I can refer them to the nurse navigator. Nurse navigator is one of the most wonderful people in the world who helps them get through the whole system. And getting through a system sometimes can be very hard from the start to the finish, and then of course afterwards. She gets them into the team approach, whether they need surgery. We've got a surgical person. If they need oncology, we've got oncologic. If they need radiation therapy, she can also interact them with a social service community people afterwards so that the person can go back to the community. And you also have a tumor board which meets once a week, which everyone gets together and gives their opinion on what the best method would be. And everyone converses, everyone talks about it, everyone figures out together what the best approach is. And then when they do figure out the best approach, we come up with a plan, which, again, with all of the new technology, is a much better plan than it would have been even 5 or 10 years ago. We have the proton beam therapy, which again goes very shallow, so we're not going to be interacting with other organs, which again, years ago when I started in practice, you gave someone radiation, it hit everything. We're now keying it to one specific area and making it shallow so that we're not interfering with the normal organs. We have the true beam linear accelerator, which we now use in cancer. You have all of the scans, and then of course the fact that you have the ability to to move the person in such a short little bits, pieces, move them up, down. As you had said, it's almost like you're almost like the captain of the ship, turning them little bits in order to get everything done appropriately and only hitting the bad parts and saving as much as possible. And the fact that, as you just described with the brain irradiation, it used to be hours. A person would be the whole day there with this thing attached to their head. Right. And it was a very, very long day, very mentally unsatisfying for the patient and exhausting for the patient. And now it's done much quicker, better, and much more exact. So with all of this technology, we're treating the patient with absolutely magnificent quality in a local facility where they can go home the same day and be with their family. They're not having to run all over the country for all of this. and with the team approach, getting quality care within a short period of time so that they can get back to life.
Yeah, yes, that's very, very true. Great strides are being made in cancer care, so that we're able to give very accurate radiation here. However, if we feel that there's something that a patient may benefit from, we may send them to New Brunswick for that, such as the proton therapy.
Which again means that the integration of Rutgers Cancer Institute with RWJBarnabas Health makes it much better for the patient. So if it can't be done at Steeplechase, the person can go to New Brunswick and be treated. And again, it's not like we're dropping care here and starting care here, especially since we're all on the Epic system. We've got everything there.
Correct. It's a huge team that is going on behind the scenes that patients don't often see. As you mentioned, we have tumor boards. This morning, 7 o'clock this morning, I had a breast multidisciplinary conference. It's every Thursday, 7 a.m. to 8 a.m. We present all the breast cancer patients here at Steeplechase Cancer Center, and we have the surgeons, we have the medical oncologists, we have the nurse navigators, as you pointed out, we have the radiation oncologists. So we have a huge team here looking at those. We have lung cancer multidisciplinary conferences. We have GI, we have GU, we have all these cancer conferences for multidisciplinary, but on top of that, we also have radiation oncology conferences so that we present all our cases to the larger team as well. And the advantage of being treated close to home is it's more convenient, it's more personalized. You're not traveling an hour back and forth for your treatment every day, which is very stressful for a patient. The transportation could be a huge issue. There's financial worries when patients have to travel for treatment. So you can get all these treatments very close to home, and you're getting a quality team, and not just touting my own horn, but you're getting everyone that surrounds me. Not just my department, my staff, but you're getting all the radiation oncologists in this area of New Jersey to participate. You're getting all the resources of the Rutgers Cancer Institute in New Jersey.
Now, you had just talked to us about the new TrueBeam linear accelerator that is over at Robert Wood Johnson University Hospital, Somerset Steeplechase Cancer Center. Can you tell us about what this, describe it? How does it work, and what kind of cancers do we use this on?
So radiation is directing radiation beams towards a target. Usually these are cancers. Once in a while, there are some benign conditions we treat. So the linear accelerator is the basic machine that treats almost every cancer we treat with radiation. There used to be some specialized software and additional packages you could put on a linear accelerator to treat smaller things, but these are all now incorporated in all the linear accelerators, particularly TrueBeam. We can treat anything from half a centimeter to 10 or 20 centimeters. So it treats a variety of cancers. It is an extremely accurate machine. As I mentioned, we have surface guided, which we're now using to monitor patients' movements, particularly when a patient, for instance, treating a breast cancer, if they're taking a deep breath, that breast may move up and down and out of the radiation parameters, and the machine will shut off if it moves too much. The accuracy of the machine is greatly improved because the imaging quality on the machine is better, so we can see more accurately the target within the body, for instance, a pancreas or the bladder. It is giving us ability to line up the patient more precisely by adding some pitch and yaw in addition to the other degrees of freedom, so that we can now create some rotations so that when a patient lies down, they're not always lying down exactly the same way they'd lied down the day before. So everything we're doing is based on a patient's anatomy. And so that starts from the planning side of radiation, where a patient goes through a what's called a radiation simulation or planning CT. And everything we do is to mimic that position forward. That's why it's called a simulation. We're simulating that position. So the patient gets planned in a certain position, and then for the treatment, we're trying to reproduce that position. And this machine greatly allows us to rotate and pitch and yaw and left, right, in, out to reproduce that position. So even if they don't lie down exactly the same way they lie down at the planning session, we can now compensate for that. We do some immobilization to try and put the patient in the exact same position, but there's always some slight variations, and that's where this machine comes in. So it's giving us sub-millimeter accuracy that we previously didn't have. We're having improved imaging to see what's going on inside the body. We can compensate for that. We now have this surface guided. We don't have to screw things into the patient's skull anymore. We can do these open frame masks for patients who are claustrophobic. So that's terrific from that point of view. And the speed with which we can deliver the radiation is quicker. And that's important because the longer the patient's on a table, the more likely the patient is to move, to sneeze, to cough. The more likely structures inside the body are going to move, so that as your bladder fills up, it pushes your prostate. As your rectum fills up, it pushes your prostate. So the idea is to give the radiation as quickly as possible once the patient is lined up, so that there's less external and internal movement.
It's just wonderful technology, and again, available at RWJUH Somerset Steeplechase Cancer Center. So if unfortunately you're given any kind of a diagnosis as cancer, it really is important to get yourself to a National Cancer Institute designated comprehensive cancer center such as Rutgers Cancer Institute to get the best quality care, get the quality care from start to finish, and of course for follow-up afterwards. As a final thought, what kind of final thoughts do you want the studio audience to know from you?
You know, the way radiation works is we see a patient in consultation and decide if they need radiation. And I'm happiest when I tell a patient they don't need radiation. So as you talked about a little earlier, Doug, you mentioned prostate cancer and early stage prostate cancer. We're doing a lot more we call active surveillance, where we're monitoring the patient. They may never need radiation. Even with some of the brain metastases now, we have some new drugs that previously would not go into the brain to treat brain metastases. But now we have immunotherapy, and these are very small particles that can enter the brain and sometimes treat brain metastases that I do not have to radiate. So not everything is going to require radiation, but it's always a good idea to see the radiation oncologist and let them make that decision or discuss that with you. It's your decision. And we're following a lot more patients. We have some clinical trials here for what we call early intervention of radiation oncologists, meaning that patients come in with metastatic disease and they may not need my services now, but sometimes they may need it. And the problem is we used to wait until someone refers the patient to us, and that could be where the patient's already been suffering in pain, for instance, for a couple of months. Now we have a protocol where patients are seeing radiation oncologists, and we're just following along, monitoring them. But because of that, we're able to say, hey, you may benefit from radiation a lot earlier than they did previously. And so we can jump in and give them some good, what we call palliation or relief of their pain. So the other advantage of being part of the Rutgers Cancer Institute in New Jersey is that we have access to clinical trials that previously we didn't have. So patients are being enrolled in clinical trials that may hopefully improve their outcomes.
Thank you, Dr. Braver. Thank you for all that you do. Thank you for helping patients with cancer. Thank you for being part of RWJBarnabas Health and Rutgers Cancer Institute. Thank you very much for being here.
Thank you very much, Doug.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call 844-CANCERNNJ. For more information about cancer services at RWJBarnabas Health, please visit us at www.rwjbh.org/beatcancer.